Hello, and let's continue our discussion on inflammatory lesions of the stomach. And we have already talked about gastropathy, we talked about acute gastritis. However, there is one topic that we need to cover for today, and that is stress induced damage of the mucosal layer of the stomach, and then we will move on to chronic gastritis. So this topic is an intermediate between acute gastritis and chronic gastritis, and it is pretty much right here. It's stress induced damage of the mucosal layer. Mucosal layer. And why are we so concerned with this damage to the mucosal layer? We have previously talked about how this mucosal layer is the protective layer that protects the epithelium tissue of the stomach from being auto-digested and damaged by the peptic enzymes of the stomach and the acid, the hydrolytic acid, that degrading acid, that HCl, hydrochloride, that is very strong, used by the stomach to digest, for example, pieces of steak, but it does not damage the stomach that contains it, because that stomach is lined and painted with mucosal layer. Now that mucosal layer, we talked about how it must be protected and how it is generated in an active process where foveolar cells secrete mucin to create for us that mucus layer. We talked about factors that lead to the weakening of the generation of that mucosal layer, and today we will talk about one factor that further damages and harms that mucosal layer, and that is stress. We alluded to how infections by Helicobacter pylori, H. pylori, can lead to damage to that mucosa. We have talked about how the use of NSAIDs would eventually lead to the diminishing of the synthesis of prostaglandins, and that would eventually lead to a deficit in the creation and maintenance of that mucosal layer. So now we will talk about how stress, even psychological stress, there is social basis for the development of ulcers in the stomach mucosal layer. There is also stress that what we would focus on today is three kinds of stress, three kinds of ulcers caused by stress, and they are known as Cushing ulcers, or a Cushing ulcer, also known as intracranial stress ulcers, and we also have stress ulcers, and we also have curling ulcers. So curling ulcers are also known as burn ulcers or duodenal ulcers, because they mostly develop in the proximal duodenum. And Cushing ulcers are the most dangerous because they eventually may lead to perforation and frank hemorrhage, blood loss. Stress ulcers are, examples of stress ulcers are, for example, ulcers caused by shock, sepsis, severe trauma. But this category is a little bit vague. But the main ulcers that develop due to clinical conditions, clinical stress, are Cushing ulcers, and they are caused due to a stress related to intracranial deficit. Okay? And they are so dangerous because they eventually may lead to perforation within the stomach, or they may lead to frank hemorrhage. While curling ulcers are ulcers that are also known as duodenal ulcers because they mostly occur in the proximal duodenum, and they are also known as burn ulcers because these are the ulcers associated with a stressful clinical condition related to a burn, for example. Then we also have stress ulcers, which are ulcers less severe in the magnitude compared to Cushing ulcers and curling ulcers. Stress ulcers may not eventually lead to perforation or frank hemorrhage, and stress ulcers are rarely found in the duodenum, but they are all caused by a stressful condition. So what you need to know is that stressful ulcers, they are endoscopically visible ulcers that appear within 3 days of the onset of a stressful clinical condition. So someone who has been subjected to a tragic episode of burn, and then they would develop an ulcer in the duodenum, then you must immediately be suspicious. Your differential must be a stress ulcer that is a curling ulcer. There's also Cushing ulcer, where a patient who is subjected to intracranial trauma, and that intracranial deficit eventually leads to an ulcer in the mucosal layer of our stomach. And this is the most dangerous form of ulcers because Cushing ulcers eventually lead to perforation, if not attended to urgently, may lead to perforation and blood loss and frank hemorrhage. I also want to leave you with something that is very important, and that is the pathogenesis of how could a stressful condition leads to an ulcer in the stomach. And that is because there is blood flow impairment. Remember, we already talked in the previous lecture that in order for that mucus layer, in order for the mucus layer to be synthesized, created, and maintained to protect the integrity of the stomach from being damaged by the peptic enzymes within the stomach, and to be protected from that hydrochloric acid, it is a very expensive and very active process. However, there are certain things that must be working efficiently for that mucus layer to be active, and that is blood flow. The stomach needs blood flow, needs oxygen. That's why when people go on high altitudes where there is less oxygen as we go high in the altitude, that will lead to hypoxia, and then an ulcer may develop because the stomach needs the oxygen, needs the blood flow in order for it to be able to synthesize and create and actively create that mucus layer, that mucus layer. So in stressful conditions, there is like a shock, and hypovolemic shock, or a septic shock, or if there is sepsis, or there is a loss of blood. So there will be vasoconstriction. There will be vasoconstrictions in the arteries that are in our stomachs, because blood now needs to be shunted away from the stomach. So now the stomach is not receiving the adequate blood flow rich in oxygen, the adequate blood flow rich in nutrients like glucose, for example, in order to create that ATP. If blood flow is not there in order to come and wash off and take all the metabolic waste from the cells of the stomach, then the stomach will no longer be able to efficiently and effectively generate that mucus layer that protects and isolates our stomach from that hydrochloric acid and those peptic enzymes. So you must remember that stress leads to a diminishing in the blood flow to the stomach, and blood will be shunted away from the stomach, and that leads to a deprivation in the amount of blood going to the stomach, meaning there would be less oxygen going to the stomach, there would be less nutrients from which the stomach cells will be able to generate that ATP, very important for the use of those enzymes. And that means the cells will no longer be able, the tissue of the stomach, the mucus layer will not be able to secrete mucus as effectively as possible, and that will lead to an imbalance where the acid will be overwhelming for that mucus layer to bear, and then the acid will start degrading that mucus layer in the stomach. Let me just go over very few and important ideas, and that is, we talked about how in the stomach the pathology is either an inflammatory related or neoplastic or tumor or a polyp and so on. And when we move on later to intestine pathology, we would realize that the intestine pathology is either related to inflammation or neoplasia, and the appendix in our gastrointestinal system, we would see that any disorder in our appendix can either be caused by an inflammatory disorder or lesion or a neoplastic lesion. So we talked about the stomach inflammatory lesions. We began with the stomach pathology. Talked about gastritis. Talked about gastropathy, and how there's a morphological feature where there is congestion in the blood vessels in the tissues of the stomach, and there is also edema and hyperplasia of cells, but there is no inflammatory cells like leukocytes and lymphocytes. And then we talked about the onset of acute gastritis, which is pretty much gastropathy. In addition to that, there's also inflammatory cells like leukocytes and lymphocytes. So the difference between gastropathy and acute gastritis is that gastritis is an inflammation. However, gastropathy is not an inflammation. And that's why in a histology, we will see that in acute gastritis, there is leukocytes and lymphocytes, but in gastropathy, there is no inflammatory infiltrate. And then we should move on to acute gastritis, but before that, we discussed today stress-induced damage of the gastric mucosa, and we said that regardless of the type of stress damage, we talked about the Cushing ulcers and the curling ulcers and the stress ulcers, the pathogenesis is pretty universal, and that is an ulcer is caused by
a diminishing in the blood flow that enriches our stomach with blood, with oxygen, with nutrients, with washing off and removing that metabolic waste. So during stress, blood is shunted away from the stomach, and because now the stomach does not have enough blood, it is not able to properly synthesize that mucus layer, and then that would lead to the acid being too much to bear and being too much to deal with for that mucus layer, leading to the damage of the mucus layer. Then in the next lecture we'll begin talking about chronic gastritis, and after that we'll talk about the complications of chronic gastritis. This is a diagram that is very important. This basement yellow layer is the submucosa. Above it, that black band, that black layer, we called it it is called the muscularis submucosa, and that blue layer is the actual mucosa, while those red dotted cells are the foveolar cells that create for us the mucus, and that mucus layer is the green layer. You see, this green layer is the layer in direct contact with acid and peptic enzymes in the core of our stomach, and they are too strong for the acid to penetrate. So acid is strong enough to digest the steak that we eat. The acid is strong enough and the peptic enzymes are strong enough to digest the chicken that we eat, the proteins, the carbohydrates, and the fats, but it's not strong enough to digest this mucus layer. So this mucus layer is actively being created and maintained and protected by the secretion of many mechanisms. We talked about bicarbonates that are enriching this layer, making it anti-acid, making it able to bring down the acidity of the acid being in touch with it. And we also talked about how the mucus layer is maintained by prostaglandins. So there is like a war going on between this mucus layer and the acid being in touch with it. In the case of a damage like we talked today in our stress ulcer, we have realized that this green layer will begin to diminish, will begin to be weakened, because it is not secreted properly. And in this case, we realize the cause is because the blood flow is weakened. There is not enough blood flow, not enough oxygen, not enough nutrients, not enough waste being removed by the blood and being taken away from this stomach. That's why we will have a deficit in the creation of this green mucus layer, and it will not be strong like that. It will be weakened, and as the stress goes on and there is less blood flow because it's being shunted away, this mucus layer will be weakened and weakened until eventually there will be a damage, progressive damage to this mucus layer, these foveolar cells, down to the mucosa. It can even go down to the muscularis mucosa and cause for us necrotic debris and cause for us inflammatory cells and granulation tissue and scarring tissue due to fibrosis. So it's very important to understand this mechanism. And we talked about how there's a tug of war between positive protective mechanisms like mucin secretion generation, like bicarbonate secretion in order to neutralize the acid in touch with the stomach, like some proton pumps, hydrogen proton pumps in the gastric cells that are actively working to pump out any hydrogen protons that leak from that acid environment to the inside of the stomach. And we also need, number 4, proper blood flow, rich in oxygen, rich in nutrients, and being able to remove any toxicity and metabolic waste from the stomach. And in this case, number 4 is not happening. In number 4, there is no proper blood flow. And number 5, we need prostaglandin synthesis. So we talked about how if there is no prostaglandin being synthesized, that means there is no mucin secretion by foveolar cells, and that leads to damage. On the other part, there is on the other side we have gastric acidity and peptic enzymes working against these positive things, and the positive things are fending off and working against the negative things. So it's a tussle. If there is damage on the right side, then if there is damage on the positive side, the negative side will win, and we will have an ulcer. And if there is empowering of the left side, then that means we will have that ulcer. So we talked about how prostaglandin is a positive promoter of mucin secretion, and we talked about the red things that may go against that, like NSAIDs, and being old in age, where these telomerase is not working properly, and we have the cell unable to divide and proliferate properly. We talked about bicarbonate secretion and how in cases where patients suffer from uremia or H. pylori infection, that bacteria has that urease enzyme that is able to secrete ammonia, which inactivates the bicarbonate channels from secreting bicarbonate, which weakens our protective mechanisms, leading to an overall overwhelming injury by the acids. We have blood flow that enriches the stomach, and today we learned in stressful conditions where blood is shunted away during times of trauma, times of intracranial pressure, times of burns. We see that ulcers develop because there is lack of oxygen supply to that stomach, that area that needs constant blood in order to maintain its mucus layer. And we also talked about the regenerative capacity of the epithelial tissue and the integrity of that tissue, and how it could be damaged by alcohol and radiation and so on. And we talked about how although prostaglandins mediate in inflammation the sensation of pain, and how inflammation has 5 components: pain, swelling, redness, heat, and loss of function. So when we feel pain during times of inflammation, we take NSAIDs like aspirin, ibuprofen, and naproxen, and that leads to the blockage of pain sensation because we inactivated prostaglandin synthesis by inactivating the enzymes that creates prostaglandins, and we said that was cyclooxygenase. So when the NSAIDs block cyclooxygenase will not be able to synthesize prostaglandin will not be able to generate the pain and inflammation, and we will feel so happy because we no longer feel pain. But we realized that prostaglandin was so important for mucus secretion, and we also inactivated that, and we inadvertently inactivated our ability to secrete mucin and maintain bicarbonate, and that would lead to overall damage because we took NSAIDs to lessen the pain, and we succeeded at that, but at the same time we deprived our bodies of what prostaglandins do in addition to the pain. Please remember the 3 kinds of stress ulcers: the Cushing ulcers, also known as intracranial ulcers, because they are caused by stressful conditions related to intracranial deficit. And they are the most dangerous kinds of stress ulcers because they lead to perforation and frank hemorrhage. While curling ulcers, also known as burn ulcers and duodenal ulcers, because they majorly take place at the proximal duodenum, and they are caused by burns mainly. And stress ulcers, they are vague ulcers that happen due to shock and sepsis and severe trauma. And you must also know that an ulcer has a magnitude. It begins over the top at the mucus layer, and it penetrates to the mucosa, to the submucosa, to the muscularis submucosa, and so on. So there is a magnitude to the ulcer. There are some erosions if the ulcer is only superficially, it's called an erosion. However, if it moves down and degrades to deeper layers of the epithelial tissue of our stomach, then it will be an ulcer. Please also remember that peptic ulcers have nothing to do with stress ulcers. Peptic ulcers are ulcers caused as a complication of chronic gastritis. We are no longer there. We are not there yet. Peptic ulcers are right here. Complications of chronic gastritis. And stress ulcers are intermediate between acute gastritis and chronic gastritis. If not remedied in time, stress-induced damage of the mucosal layer would lead to chronic gastritis. But there is no peptic ulcers to worry about at all. Peptic ulcers are caused by chronic use of NSAIDs and H. pylori, as we would learn later on. So thank you very much, and see you in our next lecture.